Well, thank you, Jamie, for the introduction, and Chelsea, thanks for coming out this morning. That talk actually made me nervous. Made me feel really old when you were putting all those dates out. Obviously, we've known Chelsea for a long time in her family, and I still remember the first time you came in and you had the minor injury and you went back and then you blew it out again, and talking about, okay, you have a labrum and a cuff and this is not good. And she said, well, I have some qualifying meet, I think in October, and this was like in July or something like that. It was like 3 months later. And I said, well, that ain't gonna work. And she said, well, you know, as everybody, you know, they think, well, just fix me and I can go back, I can do this. And then I remember that, what's that guy's name, Caroli, had Jimmy Andrews call me, because when she went back and said, well, he said he's not going to let me do anything for at least 6 months. Caroli said, that's BS, you're going to Jimmy Andrews. And Jimmy Andrews called me up and said, Bill, what's going on? I told him, and he said, God damn it, she can't come back in 3 months, just fix her and keep her out. And so then I knew the pressure was on when I'm having Jimmy call me, but I was happy that he supported me. So thinking about that and your talk and how you went through it, I'm happy to hear you're doing well still, so that's good. But I think Dan and I both watched, I went to Philadelphia to your qualifying meet, and she rocked it, and just thinking about all that stuff. A lot of time went by, and it's kind of, that's what this is all about. You know, you meet, you know, Chelsea's obviously all grown up now and has closed physes, and no longer an adolescent, but whether it's Chelsea, you know, who's the Olympian, and the majority of you are therapists, so obviously she kept talking about her therapist. You guys spend so much more time with these athletes than we do. I'm sure your emotional investment is equally or more than ours, because you know there's no better gratification than whether it's in the Olympics or on the high school football team or even playing Little League baseball. Nothing's better than we can get these kids back. And again, thanks for coming out and making me feel old, but then realizing you're old too. So, but that's great. So I guess I'm talking today about. Is my talk up here? Oh yeah. Overuse injuries of the upper extremity in the young athlete, and I basically focused on the shoulder. Obviously that's mostly what I see, but a lot of the prevention translates down to the elbow, and a lot of the problems I see in the elbow start in the shoulder anyway, especially in my throwers. Disclosures, nothing really relevant to this talk. So basically, for the objectives of this talk, put together to basically talk about commonly encountered injuries in the skeletally immature athlete's shoulder due to overuse, and really these injuries translate into those that we see in the adults too, really. So whether it's immature, other than growth plate issues, a lot of them translate into the older athlete as well. I was going to talk about some diagnostic strategies to identify the injuries. It's just kind of physical examination, proper imaging, and then talk about perhaps preventative strategies. Probably you guys will talk about that with me in questions, etc., to hopefully avoid things. And then talk about, just present some treatment plans when these injuries are encountered. So obviously you guys are all aware of the anatomy, but just the structures that can be injured in any athlete, adult or youth, certainly start out with osseous injuries. The bones of the shoulder obviously are represented here in the humerus, the scapula, and the clavicle, all creating the shoulder girdle. A lot of kids, etc., have bony injuries of any of these, and you can see how it's put together. The shoulder is obviously a relatively mobile joint because of its shallow structure, and has a great range of motion, and due to that fact, it's also a joint that lends itself to quite a bit of instability as well. You know that. More anatomy, obviously, once you have to hold the bones together and get them moving somehow, so you have a bunch of muscles in the shoulder, the rotator cuff being the big ones. most injuries that we talk about obviously involve the superior musculature in the supraspinatus and infraspinatus, the most commonly torn in the youth athlete, not as common as adult athletes, but in instability you always have to be aware of the subscap, and that's a commonly missed injury in both adults and youth athletes. The cuff is obviously a big player in powering the shoulder movement, but even more in alignment and stability. And then probably the most common thing we see in youth athletes are labral injuries, as Chelsea had talked about. The labrum obviously is a soft tissue attachment for the ligaments onto the glenoid. It's circumferentially around the glenoid, and then has the superior attachment of the biceps tendons, attaches to the superior glenoid labrum. So that's just really quick anatomy. Now, how is the youth athlete different than the adult athlete? And that's with all of the physes in the shoulder. The growth plates obviously present a unique aspect to treating pediatric patients, because those growth plates are weaker than in the adult bone, and commonly kids can have both stress injuries to that due to tension, due to overuse, and they can also have traumatic injuries, which will present some of those. So in the adult athlete, unless you're a biker, a horse rider, or a gymnast, throwing yourself all over the place, that's how they fracture. Kids can fracture easier, less trauma, and usually involve the growth plate. So what do we see, or what do as the most common shoulder injuries encountered in youth athletes? Typically, it's no different, as I stated before, than the adult athlete. And you guys have probably heard this talk a few other times when I've given it, because I do focus a lot on micro-instability. That's what we see day in, day out, over and over and over again in the office. And that has to do with mainly recognizing micro-instability and more specifically the posterior capsular contracture that occurs with those patients. And if it goes unheeded, untreated, and the patient continues to participate in repetitive overhead athletics, they likely develop a secondary labral tear and or a rotator cuff with that injury. The other shoulder problem that we see quite a bit is multi-directional instability. Probably the most typical patients that I see are the young, 14, 15-year-old swimmers. A lot of times female gymnasts are other ones that we see a lot with that. Boys can have it, but I would tell you I'm probably on about a 10-to-1 ratio of girls that I see with multi-directional instability versus male athletes. I think a lot of that is hormonal as well, as that can affect tissue flexibility, etc. Other injuries that we see in the shoulder, repetitive stress injuries, fractures, epiphyseal injuries, little league shoulder, that sort of thing. We'll talk about it. And then obviously kids throw themselves all over the place. Chelsea was kind enough to give me an ulcer during that whole talk about her shoulder, but remember, she broke her ankle and her foot and did all that sort of thing. And certainly we see a lot of fractures in dislocation in kids, and then AC joint injuries as well. So we'll kind of touch on all of this. So I was going to start with micro-instability, talk about what is micro-instability, what is its defined pathogenesis pattern, what athletes do we need to be concerned with, how does it usually present, and then how do we treat it? The guy who I trained with, Gene Wolfe, always gave talks and was always quite colorful. And when I was training with him, micro-instability was kind of in its early stages. It was in 1999, and there were all sorts of, it's when we were shrinking capsules with wands, and we really didn't understand too much. And he would always get up there and say, at major talks, and say, I don't know, why you guys are all worried about micro-instability, because, and this is to orthopedic surgeons, by the way, this isn't to anybody else. He said, because half of you don't even know how to recognize macro-instability, and when a shoulder, what direction it pops out, or if it's popping out at all, and you screw people up all the time. What are you worried about micro-instability for? And I'll tell you, that's probably the controversy still exists, and there's a lot of different things, but I think that it's pretty well been figured out. The three theories that are out there, Walsh talked about internal impingement. He was the original one to talk about that you had basically internal impingement of the rotator cuff on the posterior superior glenoid, causing undersurface tear of the posterior superior labrum on the cuff, so you would have kind of adjacent lesions there. And he said, you know, this was just a phenomenon that happened because of hyperexternal rotation, and that was what micro-instability was. Job then said, yeah, well, because they're doing that, what's happening is the shoulder's kind of gradually stretching out in front, and you're getting even more translation, so those two kind of combine together, and that's why we started shrinking capsules and that sort of thing. Later on, Steve Burkhart and Craig Morgan basically recognized and brought the attention that all these patients also had this posterior capsular contracture, and it presented as a glenohumeral internal rotation deficit, or that these throwers had a decreased internal rotation on their side, or swimmers, or whatever the athlete may be. They would have decreased internal rotation of the shoulder versus the other side, and that would lead to the cascade that basically Walsh and Job described of capsular laxity and micro-instability of the shoulder. So I think all of those put together are what defines a micro-instability pattern. And again, this is certainly in all of the kids that come, not all, but I mean the majority of the injuries that we see that come into our office, certainly. So shoulders in athletes performing repetitive overhead athletics do, in time, initially they remodel their glenoids through throwing from ages 8 to 14. They'll actually remodel their glenoids to the point where they will have hyperexternal rotation of the shoulder. Okay, so that just needs to be recognized when evaluating shoulder motion. And that's if you basically see a thrower versus non-thrower. Now swimmers are different because they'll just be hyperlax because they use both their arms. But if you're looking at a right-handed pitcher, you look at their mobility, and their right shoulder will go back, like this, and their left shoulder will go back like that. So when you're examining a patient, you have to take that into account. But with overuse, you'll notice in these patients that they'll have a decrease in internal rotation when the arm is abducted compared to the other side. Why did that happen? We'll talk about it, but and we'll also talk about how to define that. So the pathogenesis in developing a posterior capsular contracture of the shoulder is one that and I'll talk about throwers, but you can also talk about this in other athletics. When you do repetitive, overhead motion and releasing the ball, upon the release of the ball, your entire body weight is released anteriorly out of your arm in a vector of pull such as this. So your shoulder is continually trying to be anteriorly translated. In the normal glenohumeral relationship, your anterior musculature will resist that anterior translation. Everything's great. So for instance, early in the baseball season, you're fresh. Well, theoretically now kids seem to throw all year, but early in the season, you're fresh, the kids do great, they're throwing, and then as time goes by, your anterior musculature will weaken and fatigue, and what happens is then you start getting just slight anterior translation every time you release the ball or hit a volleyball or swim or whatever these kids are doing. They will get just a slight anterior translation due to anterior muscular fatigue. The result of that is that the shoulder goes anteriorly and you get the rubbing of the posterior capsule on the posterior glenoid, and it will create an inflammatory process, a posterior capsular contracture. And that posterior capsular contracture not only will restrict your motion, it'll also help push the shoulder forward even more, resulting in, if it goes on over time, first a labral tear, usually of the posterior superior labrum, and then rotator cuff pathology if it goes unchecked. So the third stage of it is the posterior capsular contraction, then developing of a sixth scapula. And sixth scapula is obviously a scapular malposition where the scapula is inferiorly and medially rotated. The medial border of the scapula is inferior medial border is very very prominent. The coracoid hurts because of pectoralis contracture, and then there's obviously dyskinesis of scapular movement. Real important to take the patient's shirt off and see that. What you'll see is they'll look lopsided. You know, if it's a girl, you'll think that she has scoliosis, but the patient will literally look like their trap is almost missing on that side. And if you take their shirt off and look from in back, it'll look like they have no trap, and it's basically the shoulders just like that. So who are the athletes at risk? Throwers. Obviously for the kids, usually your best pitchers are also playing like shortstop, third base when they're not pitching. My favorite is when they're pitcher-catcher combinations, and I try to talk to coaches and dads and say that's not really a good thing because catchers' pitch counts are always, you know, high. Then they'll put them in. But the 14-year-old glory is more important than anything in a lot of these kids. Swimmers, volleyball players, tennis players, and gymnasts are people that we see with this quite often. So presentation, patient comes in, basically says, you know, I have a painful shoulder, I get a dead arm, I fatigue very easily. If they are throwers, they'll you know, be talking about, you know, I just can't throw strikes anymore, I can't throw as hard as I used to throw. Sometimes they'll also complain of a little bit of numbness due to tension in the brachial plexus, goes down to the fingers. And then their physical examination finding is the glenohumeral internal rotation deficit, and I basically put this slide up there. As we talked about, obviously throwers or overhead athletes have hyperexternal rotation that you have to take into account. So you basically look at how the patient moves their arm. I do a lot of mine standing because you can really tell, but you can put them down on a table and basically measure the arc of motion the guy I trained with, Gene Wolfe, would say, you know, he called this just total rotation, and basically say, okay, if this is 120 degrees on this side, for instance, you know, look at their contralateral side and compare it. If it's a significant difference, you know, 20, 30 degrees, a lot of these kids will have 45, 50, I mean, you can't even get them down. A lot of these kids will have internal rotation like this, you know, 90-degree almost loss of motion. Pretty significant and really important to recognize in kids. And I'll just kind of put it out there, a lot of you guys treat kids as well as adults, post-surgical patients, really a thing to recognize in all of those patients, because that will cause, you know, secondary impingement and dyskinesis of the shoulder. They will have a positive O'Brien's test, you know, resisting forward flexion in an adducted and internally rotated position. When I see these patients, I'll obviously look at their glenohumeral internal rotation, and then their O'Brien's test is a key for me. If you have a patient who, you know, this is presenting, they have internal rotation deficit and it's been for 2-3 months, that usually, you know, you guys can really help with. If it's a year, you worry about it. I also use the O'Brien's test as kind of a prognosis when I'm thinking about imaging people or what I'm telling them on initial presentation. If they have a great O'Brien's test, just posterior capsular contracture, that's a really good sign. If they have O'Brien's test, but it's really strong, but they say it's painful with an internal rotation deficit, I say, well, you know, you're a little bit at risk. If that O'Brien's test just goes, oh, you know, that hurts, that's a real bad sign. Usually that's, in my opinion, is associated with a labral tear, and I image them pretty quickly. So, and then obviously you look at scapular position and then rotator cuff strength. So, how do we treat it? If it's just a posterior capsular contracture, it's rehab, 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 and it'll get better. You know, it really, there should be no reason why an isolated posterior capsular contracture does not get better. If it doesn't get better, if they don't get back to it, it's usually because, number one, they're not doing their exercises, the patients that is, or number two, because there's some other pathology along with it, so if they haven't been imaged, you should image it. And then after you get their motion better, remember, this whole thing starts because of fatigue of the musculature and the stabilizers around the shoulder. So the key in prevention and the key in all of these athletes is, number one, taking a little bit of time off during the year from whatever they do, cross-training, doing other types of sports. And I mean cross-training as in doing other sports. I don't mean that CrossFit stuff. But two, keeping the shoulder strong and getting those anterior stabilizers especially back on board so you can maintain your normal kinematics of the shoulder. If we need to image it, I do, for all of these, I do like the MRI arthrogram. You can, if it's a better MRI scanner, if some of the 3Ts, you can certainly see it. If you get the films to look at and you see enough of these, I think that we're pretty good at recognizing even without the arthrogram, but it's real. I think things are still missed a lot of times, and if you're going to get a scan, I still believe in the arthrogram. There's a little controversy as to whether you know, the dye in the shoulder and that sort of thing, but I guess I'm still old school and I still do that. So the people that we talk about doing surgery on are obviously those with labral pathology and rotator cuff pathology, and then when we're doing that, if we can't stretch their posterior capsule, if it's still there, we obviously do a posterior capsule release with it. I think we have some cases that show that in a little bit. So obviously in micro-instability is kind of a wrap up. Don't overlook the posterior capsule, okay? Posterior capsule is the key in recognizing it, treating it. Always assess the glenohumeral internal rotation. And if you catch these patients early, like I said, if it's a kid who comes in 6 weeks, 3 months, that's awesome. When they come in and say, last season it started hurting me, you know, then the fall it was kind of tough, and it just, you know, when it's a year out, that's when we image them and they don't have as great of a prognosis. If they do have a labral tear and a rotator cuff tear associated with posterior capsular reconstruction, you'll still, or with a posterior capsular contracture, you guys will still see those patients from us, because I'll tell them, hey, we can still try to stretch you, we can still see how you do, but the prognosis of that injury in those athletes with just therapy is much less predictable. Again, I talked about painful O'Brien's but strong, and with the glenohumeral internal rotation deficit, therapy really has a good chance. If that O'Brien's drops, it's not really going to be as predictive. And then again, prevention, just always the key is you get them better. Okay, they go back next year, make sure they remember the sleeper stretch, make sure they remember those exercises, and that's basically once, you know, that 14-year-old kid, 15-year-old kid presents with a posterior capsular contracture and micro-instability, that's a shoulder. I tell those kids, you have a shoulder at risk for the rest of your life as long as you're doing sports. Okay, I said if you want to stop doing sports, you probably don't have to worry about it, but you have to remember your exercise. You have to put that into your program, and those are the ones that come back. I always say, well, how's your sleeper stretch going? How's your band exercises when they come back the next season? How'd you keep your shoulder in shape? And usually the mom looks at them and says, see, I told you should have been doing those exercises, and that's the key, is just making sure that they stay it. So what other shoulder instabilities do we see? Multi-directional instability, okay? A lot of the gymnasts, a lot of the swimmers, a lot of times this is female directed, and basically the old acronym for it was Ambry instability. This is atraumatic, meaning, you know, Chelsea doesn't say, hey, watch this routine, and that's where I hurt my shoulder. This is, I've been swimming, I've been doing my gymnastics, since I'm practicing, I get sore, I'm sore all the time, I sit here, I'm sore, it's getting worse, it's getting worse, it's getting worse. Well, when did you hurt it? I don't know, it just got sore as I'm doing my sports. So they don't usually have a specific time that it hurts them. The M is for multi-directional, meaning the instability is in a lot of motion planes. You can a lot of times sublux these people posteriorly out of the shoulder with a posterior jerk test. You can get them down with a significant sulcus sign when you pull on their arm, and you can basically see a huge indentation between the acromion and the humeral head. A lot of times it involves both of their shoulders. This is an entity that, again, usually you guys can have great success in getting them better with rehab, strengthening the shoulder stabilizers, and if it doesn't work, the way you treat it is with an inferior capsular shift. You can see the picture here is just showing, you know, the shoulder sulcusing, you know, where it's kind of, when you pull down on it, basically the shoulder just moves around quite a bit. So kids. The humeral epiphysis, this is also true around the elbow. Little league shoulder, very common thing that we see in these athletes, and it's basically an injury to the proximal humeral growth plate caused by repetitive overhead throwing with improper mechanics usually. Also, these kids are usually not in great condition. They aren't sitting around doing their band exercise, that sort of thing. They don't have good endurance, and bottom line is it's because they're throwing too much. Okay, that's the thing. You always see these people, they're always brought in by their dad who coaches them, and the mom's sitting there and they always say, you know what, but I'm really good. I really watch how much they throw. It's always, for some reason, the really, really good coaches and the really, really good parents are the ones who come in and say, no, but we really watch them, we really watch them, we really watch them. And then you talk to him a little bit more, and the kid's on his community team, he's on 2 travel teams, and plus he's going to hitters, 3 times a week to work on his stuff with his pitching coach, and you find out that they're probably throwing about 1,000 times. I mean, they're still great parents and great coaches. They just want their kids to be, the number one guys. So how do you treat little league shoulder when they come in? Oh, bottom line, I'm sorry. I think this is a picture of what an x-ray looks like. A lot of times the key is in this, number one, recognizing an aching shoulder, kid with a growth plate. What am I doing here? There's triggers all over on this thing. There we go. Recognize it. 2, X-ray. That's all you need, and you can see how you'll see this widening of the lateral physis of the humerus. A lot of times we'll order bilateral X-rays so you can compare the throwing versus non-throwing shoulder and show folks what's going on there. Sometimes I see them come in with an MRI scan, and there will be a lot of edema in there too. So how do we treat it? Obviously, number one, rest. Okay, it should be almost 6 weeks usually, at least, of keeping these kids off, and then treating them with some physical therapy for pain relief, motion restoration. Notice I'll put posterior capsular contracture in almost every slide. If you're taking one of our orthopedic tests, we have to take these in training, not in training, what are they called? Recertification tests, right? And we have to take these like review, self-assessment things, and once in a while, one of my partners will call me and say, hey, here's this question, what do you answer? Before he even gives me the multiple choice, I say posterior capsular contracture. And that's like the answer on all of the questions. So I'll emphasize as much as I can here for you, because when it's not recognized, obviously it doesn't do well. So you treat that posterior capsular contracture, work on their muscle, and then education. And this is the most important slide that's there, and I encourage you guys to get that in your office. I coached youth baseball for a lot of years. I have 2 boys that are now in college, but I coached them from 8 years old on till they went to high school, and then the high school guys took over. We had 12 kids on our team, played a lot of tournaments. I was one of those nutty patients that, yeah, my kid did all of that stuff. But the one thing, especially with the team that I coached the most, we had 12 guys, all 12 kids pitched. And I just said, that's just simple throwing. And it was my philosophy. I mean, we would go to tournaments, where, and I'm sure a lot of you guys have kids who play in these tournaments. We would show up to a tournament where you play 4, 5, 6 games in a weekend, starting a Friday night till Sunday if you got to the championship. And literally, we would go out there. I would always pick the tournaments that there was no lineup restrictions. You could bat everybody could move around. And we would pitch 6 guys. 6-inning game, we'd pitch 6 guys, different guy every inning. Do that sort of thing. Because you can see on there, if you have these kids, if you keep them under 20 pitches, okay, if they go out there and they pitch 20 pitches, they don't need any rest. So we would just do that through a tournament, and it was crazy. These coaches would look at you like you were nuts. And then conversely, we'd be playing against these teams that would pitch the same kid 6 innings. I'd be doing pitch counts on their kids. They'd be up over 120, 130 pitches because we could hit the ball. We were a good team. It's crazy, the stuff that you see out there. If you look at, especially the middle chart, it's a really nice use of pitches, how many days rest they need with that, and if you do that, all those kids that I coached on my Joyce team, we don't have any kids that have any shoulder surgery. I mean, it's that simple. You don't overthrow them; they'll get on to the next level. They'll be able to play high school. It's going to be great. So pitch count is really important. So in Gene's honor, I decided to put this slide in there. You know, macro instability. I mean, obviously that's something we see in kids, shoulder dislocations, called Tubbs instability. It's usually traumatic, unilateral. That's usually associated with a Bankart lesion or a tear of the anterior inferior glenoid labrum and inferior glenohumeral ligament, although it can sometimes tear off the humeral side as well for a Hagel lesion, and usually requires surgery to fix. You know, young active athlete, I think we're going to talk about it later, but you know, they have a very high recurrence rate despite anything we do if they're going to remain young and active. So, what do we see as far as osseous pathology in the shoulder? Fractures of the clavicle and humerus, as you see pictured here. Growth plate injury right here. I do see AC joint osteolysis occasionally in my 17, 18-year-old big weightlifters, that sort of thing. And then AC joint separations that we see in youth athletes. Just remember there's a physis out there. Usually those separations are fractures and can be treated well non-operatively as well. So I did put a couple of cases in here that I thought we could maybe prompt some discussion or present and show the pathology. First case is a 12-year-old pitcher, plays on his community team and travel team. Dad coaches who really watches how much he pitches, and usually they say he also has perfect form, which when coaches say, you know, even high school coaches, they talk about, no, this kid's got perfect form. Usually that just means he throws a lot of strikes. Okay, that's when a coach at those levels say he's got perfect form. He throws a lot of strikes. At 12 years old, he works out year-round at, you know, fill in your Blake place because he's already a D1 prospect. You know, I've heard about like 3 kids now who are freshmen in high school who have verbally committed to, I think one's to TCU, one's to Louisville around here and somewhere else, that they're freshmen in high school. One's a sophomore, I think, and so it's crazy. At 12 years old, they're already thinking about this stuff and saying, oh, he's going to play D1. Freshman year, they're verbally committing until probably about the middle of their junior or senior year when they get hurt, or that coach never sends them that paper to sign. So I think that can happen. But these are what we see. So he stopped all other sports. He's not playing anything. He's just focusing on baseball. And when he's not pitching, he's playing shortstop. And he has pain in his arm with diffuse weakness and a loss of velocity. This is pretty easy. I set this up for what it is. Eric, what does he have? That's why Dr. Peifel is one of the bosses here. He's right. You can see his x-rays here of his 2 shoulders, and you can see the difference in the physis. He does have little league shoulders. So treat him with rest, and education. Focusing on other sports. I can't stress how many baseball players I've seen, especially where I live. A lot of the guys, quit playing football, quit playing basketball, quit doing everything to focus on baseball. And we do have a college baseball player here. Josh, how many guys do you know who play with you or that you know are playing college ball just played baseball? Just played baseball? I should have prompted him on this. I was going to say I don't see many guys. Josh actually is a D1 pitcher, and he played soccer, he played basketball. I was going to say most of the kids that I see, and my son played with Josh. He also plays college baseball. All those kids, they played 3 sports. It's really important for longevity to play to cross-train yourself, use other muscles, get yourself strong. I don't see a lot of kids who make it just playing baseball. And maybe he plays in Florida though, so those guys are nuts. So maybe that's why those Western guys. But I think all of them are. I think you said you had a ton of injuries on your team too, right? So maybe that's why. See, so he's making my point for me. So speaking of baseball, next case is a 20-year-old male collegiate baseball player. Has dominant arm and shoulder pain, weakness, positive O'Brien's test that manifested weakness and pain, tight posterior capsule, and has pain with rotator cuff provocation. So this is, obviously we've talked about this. This guy, we actually did get an MRI arthrogram on him. And by the way, he had also done some physical therapy. where he went to school, wasn't working. And you can see on the scan, he does have, this is just a regular, was this an MRI arthrogram? Yeah, it was our MRI arthrogram. And you can see he just has a subtle little tear. This is anterior, this is posterior. You can tell there's biceps tendon. Don't get fooled by this. That's the middle glenohumeral ligament coming down. Here's the anterior labrum, come around posterior labrum. Suddenly this looks just a little different here, and there's that subtle little tear there. So he does have a posterior labral tear associated with this pathology. So obviously we went to the operating room with this guy, if I have pictures of his shoulder, and this is just showing his arm in a lateral decubitus position. Humeral head is superior, glenoid is inferior as they're laying on their side. Patient does have a pretty decent looking rotator cuff. But as you can see, his posterior labrum, this is looking from a superior portal, his posterior labrum certainly doesn't look all that great. Looks pretty worn. After we clean it up a little bit, you can actually appreciate his labral tear. Again, this is how you fix them. You basically use these stitches, some anchors, put it in. And you can see there's his repaired labrum. Now, interestingly, again, I told you he had a posterior capsular contracture. Clinically, this is what it'll look like. Again, I'm looking superiorly, and you can see all of the inflammation in his posterior capsule, and you'll just have to trust me that this is a pretty thick-looking capsule of the shoulder, and this is what obviously led to this whole problem. So in addition to doing the posterior labral repair, we perform a posterior capsular release to help him with that type of motion. So that's other case. And then this is just a third case of a 17-year-old female swimmer. She's complaining of pain and fatigue while swimming, but also they'll complain about diffuse achy pain even at rest. They worsen as their practice time increases. They do have hyperexternal rotation, positive sulcus sign, and painful and weak O'Brien's test. On her, we get an MRI scan, arthrogram, and you'll see the difference here is, the capsule is patulous, but you don't see any really difference in the labrum. We just took a couple of slices here to show you anteriorly and posteriorly the labrum look similar, but you can see that they do have a lot of capsular patulousness. Okay, going to her shoulder, cuff, bicep, everything looks great. Joint looks good, but what I oftentimes will tell the residents or a fellow if he's with me is a lot of times you go into the shoulder and there's just a ton of room to move. You just have to appreciate the fact that humeral head, glenoid, and I almost talk about the glenoid a lot of times look like a volcano coming up here. It's just a lot of room to move. The humeral head will be inferiorly subluxed in relation to the glenoid, and again you see the glenoid and all this room in the capsule here. And again, this is the inferior capsule looking down. What you do to fix this is you basically do an inferior capsular shift where what you're just trying to do is just decrease the capsular volume of the shoulder. So the first thing you do is you just abrade it to make the tissue bleed, and then you do that with a shaver. I think this was a video, but I don't think it probably, oh, it did come over. This is how you abrade it. You use a slotted whisker shaver, just kind of paint it over the capsule to make it bleed. I'll just show you. You'll see it's a white capsule, and I think I actually will turn the pump off just to show that we got it. You can see the blood coming out of the capsular tissue. You see it actively bleeding, and once you see that, you know that you can sew those surfaces together and they'll heal. But for putting in this, you put some stitches in. You basically grab the capsule down here deeper and bring it up to the inferior labrum, inferior glenoid, and you basically put these stitches in you can see the difference now of decreasing the capsular volume of heels together. So that's an inferior shift for multi-directional instability. So, and I think that's all I got. So.